Well, back at it. Back with our next recorded podcast.
Yeah, welcome to the next edition.
How's it going, Jeannie?
It is going wonderful.
That's great. That's great to hear.
Yeah, a beautiful day here in Michigan. I had a wonderful weekend, and now I get to spend time with you.
Oh, you're just saying that, but I appreciate that you're just saying it. It looks like it's going to storm, though.
I also love a good storm.
Yeah, I do too.
So, Rob, what do you want to talk about today?
Let's talk about pain.
Ooh.
And I'm going to try to start off with a story like you did before,
Okay.
but I don't know that I have your mojo. So we'll see what happens.
Okay.
But the setting,
Mm-hmm.
this is pre-Vietnam War in Vietnam.
Mm-hmm.
There's a lot of political strife going on. There's problems with the government, and the at that time Catholic president was instituting all kinds of regulations and things against the Buddhists, and the Buddhists did not like this. So there were protests, and protests became violent, which made the protesters even angrier. And this led to an incident which happened with a Buddhist monk who I will not try to say his name because I would butcher it. But this is in 1963, and in order to protest the government, a 60-some-year-old monk walked into one of the busiest streets in, I'm not sure what city they were, but sat down in a lotus position and had two of his fellow monks douse him in gasoline. With a full crowd looking on, he lit a match and was engulfed in flames and continued to sit there peacefully without moving, without flinching, until he died a minute or so later. And other than just that story being horrific, because that's a true story, this is from the photo of the burning monk. Other than that just being horrific, it strikes me as the thing that would be the most painful thing I can imagine.
Yes.
That would be amazing pain. And yet this person was able to withstand that
Mm-hmm.
without at least any external
Like obvious
outward
sign
problem,
of distress. Yeah.
which is amazing. And it tells us that pain is more than we think. It's more than just something cutting your skin or spraining an ankle.
Yeah. And I wanted to talk about pain because so many times patients come and they may say, I was told this condition doesn't have pain, or, I'm not being believed about my pain. And because it's one of those invisible inside symptoms, it can manifest so differently in people, but be such a big part of, how it affects their quality of life and even just how they spend time with family and the things that they can do. If you have terrible pain, that takes away from you. It's draining.
Pain in any form is something that takes away how you're thinking, how you're concentrating, and it's going to affect everything.
Yeah.
And it is a big problem for a lot of people. We treat a lot of patients with multiple sclerosis, and in the textbooks, multiple sclerosis does not include pain. In the real world, it absolutely does.
And all kinds of pain, not just one kind. The body is fascinating in the different ways it will manifest feelings of pain, and in the different ways you have to treat those types of pain.
Yeah.
So, Rob, what is your knowledge about remote or old, weird pain things, ways to treat pain? Anything crazy that you know? Interesting
that you would come up with that random question completely out of nowhere.
I'm not prepared at all with notes to read off of.
I just happen to have a list here. Well, I looked up a bunch of stuff, most out of curiosity, but there's evidence of people using plants for pain relief up to 4,000 years ago.
Mm-hmm.
People were using the poppy plant, mostly in Asia.
Mm-hmm.
That's where heroin comes from, and opiates and morphine and things. Coca plants were being used in South America. That's where cocaine comes from, and that's been used for a very long time. There's been doing all kinds of different procedures for pain, bloodletting and acupuncture, and these are things that do lead to some benefit and have been used for thousands of years successfully. I found one particularly fun thing, which was the use of electric fish
Tell me about that, because I'm not familiar with that.
So this was something that was the Roman times. People were doing this, and the story, which might just be apocryphal, but a man who had problems with gout and accidentally was electrocuted by a fish and felt better, and then everybody started swimming with electric fish.
So it's kind of like the original TENS unit.
It's the original TENS. It is the original TENS unit, yeah.
Nice.
Well, TENS units we can talk about in great detail. But somewhere around 800 years ago or so, people started using anesthesia in procedures. And the first time people tried to do anything other than bite down on this leather strap and try to not die. And that has been evolving ever since. A dentist in the 1800s was the first person to start using inhaled ether, or at least giving the public demonstration of inhaled ether to do dental procedures. And that in the 1850 or so was when people started using chloroform. It turns out that that's not a great idea, but it will knock you out. And then sometime in the 1800s, when more and more people were using morphine and opiates, physicians started to say, you know what, this might not be a great idea. Maybe it's not a good idea for everybody to be using morphine or opium all the time. And that is still something that many people are struggling with today.
Yep.
Opiates include things like morphine. They come from the poppy seed. And heroin is a very potent example of that was initially sold over the counter for cough for children. But
it's interesting, though, how some of these, no longer are in existence, but some of these still exist today, hundreds, thousands of years after the fact.
Yeah, there are so many things that nature seems to have built-in ways for people to escape pain, because it seems to be something that's a big deal. But different herbal remedies and plants have they're not just that they're still used, but they've kind of evolved into many of the things that are mainstream in Western medicine today.
Well, and I perform medical acupuncture. After I finished my fellowship, I thought, what can I learn next? So I completed training for medical acupuncture. And that was fascinating, because it was such an East meets West kind of experience of really learning these traditional Chinese properties, traditional Chinese medicine, and then seeing how contemporary physicians were taking this data and really turning it into more contemporary treatment plans, whether it was with nutraceuticals or functional foods or the acupuncture or acupressure. And it's been really interesting to see through my own application of this for patients, where I've been able to make some inroads. And even for myself, that's just been a very interesting experience to see this connection.
So when you went through your training for
Yes.
that, what did that entail?
So hundreds and hundreds of hours of lectures, and then a hands-on seminar that was a few weeks in person, all the physicians going through the training at the same time.
Who was training you?
You're putting me on the spot. I'm forgetting his name. It was a very nice gentleman. And he wrote a very funny song about acupuncture that we all had to sing on one of the days. But it was really interesting. We map out all of the acupuncture spots, and we're practicing on one another, and really kind of learning the different formulas based on what the presenting symptoms might be. And I'm just a big believer that you should always have more than one way to approach a problem. There may be a preferred way, but you always need to have more than one path forward.
Yep.
For any problem. So that to me was what this was, is another tool to try to reach my patients with whatever the symptom might be.
That's awesome, because there's too much of a division between Western medicine, quote unquote, and Eastern type treatments. And it turns out that people, they do things for thousands of years. There's probably a reason.
Yeah, I don't pretend to know everything, but I respect that this practice has continued, and there must be something to it.
There must be something to it.
Even if we can't identify every piece of the pathway, it has value, and it's safe.
That's one of the things I like about you, Jeans. Look at all kinds of angles. It's great.
Well, thank you.
You're welcome. So, what is pain? Why does it happen?
So pain is interesting.
It's a lot. Yeah.
because we have more than one kind of pain. We feel pain in different ways. Our brain processes it through different pathways. But one way that I think about it is a stimulus or something interacting with the body. That message gets carried inward through nerves, up your spinal cord, into your brain where it's processed into a feeling. And you can sort of divide it into a few different types of pain. You can have nociceptive pain, which is like if you stub your toe or burn yourself or cut yourself. It's a painful stimulus that your body is perceiving. And then I think there's a big category that we're better understanding as far as neuropathic pain, and that is pain that is really driven by peripheral central nervous system disease, sensitization, these central pain syndromes that I think are getting a lot more attention and understanding, and then inflammatory pain. So the more kind of conventional, when we think of swelling and heat and inflammation, that sort of pain. I kind of lump it into those categories so I get a better sense of where I need to look either through imaging or other testing if I'm really looking for a problem, a fixable problem, and really how it guides my med management.
Yeah.
But if you want to drill down into the more nitty gritty, you are welcome to.
But
that's at least how I think about it broadly.
I love the nitty gritty.
I know, you're so good at it.
Well, so there are, one of the things that I try to talk with patients about are that pain is something that's way more complicated than they might think.
Yep.
So you can think of a simple way of causing pain. You damage tissue, you cut somebody's skin. That causes the nerves in that area to sense the damage. They send a signal to your spinal cord that there's something wrong. That signal will translate into a reflex that will kick in well before you ever have any experience of pain whatsoever. Mm-hmm. If you step on a hot coal or a sharp thing, your foot's going to come up way before you ever say ow. So that happens because there's a lot of sort of checkpoints along the pathway from that skin cut to your brain. Your spinal cord, one of the main things that it's doing is filtering out the information and keeping you from having to experience every little thing that your nerves sense. There are pain signals coming all the time whenever you move around, you stretch mm-hmm. things a little bit, you sit too long, but we don't become aware of them because our spinal cord is filtering out a huge percentage of that right off the bat. But there's information that gets up through to the brain, to lower parts of the brain like the reticular activating system, that then decisions are made about. Does this need to become conscious? Does this need to be something that my muscles deal with immediately? And that's where we get into more of the sort of the more affective component of pain, the emotional mm-hmm. component of pain. Because pain is something that doesn't necessarily need to cause suffering for people. Pain and suffering are kind of different things. Mm-hmm. And the suffering component comes from all the other brain connections that are made once you feel pain. Yeah. It's the dread of having more pain. It's that feeling of this is something that is bad for me and is going to cause more problem. And oftentimes that's the part that is the hardest to deal with.
Yeah. One of my favorite things about thinking about the pathway of pain is myelinated versus unmyelinated pain fibers.
Whoa. All right.
And
slow down.
And I mention this because every time I burn myself on an oven, I always think about my nerve fibers. So we, to elaborate a little bit, we have nerves that are receiving the pain signal, but some are encased in a fatty insulation and some are not. And when you insulate something, it just moves or propagates that nerve impulse very quickly, and that speed between foot to brain is instantaneous. But when they're unmyelinated, they're slower. And so temperature is traveled or carried by the unmyelinated fiber. So what that means is when you touch something hot, there's a few seconds before your brain registers it's hot. And I just always think that that's such a fascinating phenomenon because you can see that you're touching something hot, but it's that 2 to 3 second lag before you feel it.
Oh boy, here it comes.
And every time I'm like, oh, I wish those fibers were faster. I would have pulled my hand away quicker.
Yeah.
I think that's just one of the most interesting ways to think about pain from a day-to-day standpoint is just that example right there.
And that's why you're feeling that slow, throbbing,
yes.
just gnawing pain, because those fibers are not sending the signal as fast as, say, getting poked with something sharp. That signal mm-hmm. is physically transferring slower to your brain. It's I don't know. I'm assuming. Well, what's the number of times you've had a patient tell you this, or say something like this, which is, "This is something that really hurts me, and it really hurts because I know I usually have a very, very high pain tolerance."
More than 50%.
More than it happens all the time.
Yep.
And the thing about pain tolerance is that is a completely subjective measure.
Mm-hmm.
When you induce pain for whatever reason in somebody, there's no way of quantifying how big of a problem that is for one person versus another person. We know that there are some things that play a role in how people experience pain. So there are genetic conditions. So there's a genetic condition that's super rare, but where people have a congenital analgesia, an inability to feel pain. This is related to aberrations in a gene, and it's something I think that there's less than 100 cases reported. Did you ever see the movie The Girl with the Dragon Tattoo?
Yes.
So the creepy guy in the movie who was, I think it was like her brother or something like that, and I don't think he says much throughout the movie, but he's the thing that's interesting is he can't feel pain, and they portray him as this brute that can withstand being hit and kicked and all kinds of things without any problems. In reality,
I was going to say, you need pain.
Yeah.
Pain is important to tell you, I shouldn't do that again. Yeah. That's not good.
People with this condition have a ton of problems. They break bones. They
twist ankles, I imagine.
Even just when you're sitting for a long period of time, there are signals that say, hey, I need to shift my weight a little bit. And if you're not getting those things, I can imagine, when babies are learning to do things, pain is a big part of how they figure that out. You start chewing on your finger and it starts to hurt, you stop doing it.
Yep.
So if you don't get those things, it can be disastrous for people.
Yeah, for about a year straight, all Fitz said was, I touched a light bulb. Whenever you said, how are you doing?
And what does he do around? Probably doesn't touch light bulb
Nope,
anymore.
never happened again, just the one time.
But the tolerance to pain is something that is kind of different for different things.
Yeah.
And it's not the same for one person all the time. I mean, I can tell you that I'm the opposite. I'm a total wuss. And most of the time I whine and complain for hours whenever I'm in some sort of pain. But sometimes I can go through the same thing. It's not quite as bad. Sometimes it's worse. There's a lot of factors that will change how that feels.
When I'm having a migraine, I always find it fascinating how tender my scalp is. Like, my head hurts to touch when normally it doesn't.
Yeah.
And it's not that the skin is damaged, but just my perception that allodynia, that's happening during the pathway of a migraine, I think is another good example of how your perception of pain, even just day to day individually, can change based on what's going on.
Yeah. Chronic pain is something that is very tricky. It is debilitating, and it's sort of categorically different from immediate pain. It's not the same as something as when someone gets cut or twists an ankle or whatever it is.
Yep.
And I think that the best way of describing what is happening is that the brain's job is to learn. Mm-hmm. That's what it does. It does it incredibly well.
Yep.
It does it really well, including with things that don't necessarily help us.
Yes.
So learning happens at a lot of different levels. There's learning that happens at the level of the nerve. There's learning that happens at the level of the spine, and at many levels throughout the brain. So when something is there that causes constant pain stimuli, and you get repetitive firing of certain pathways, your brain does what it does well. It learns to experience that, and that can be something that is incredibly hard to unlearn.
Yes. Yeah, absolutely.
And when I'm saying learning, that can be a confusing thing, because that don't necessarily mean that that's something that people have any conscious control of doing. You learn all kinds of things subconsciously. You have reflexive movements and things like that, and it's the same with sensation as it is with...
Yeah, it sort of becomes the new normal, whether you asked it to or not, and regardless of whether that is a survival benefit or not.
Yeah. What how do you think about somebody that has chronic pain, and what kinds of things do you do to sort of start trying to help?
It's super individualized. So part of it is if I think it has any structural basis. So if there's a lot of spasticity, I'm going to try to target that. Or if there's a lot of bone pain that's contributing, or if there's any underlying depression or anxiety or sleep disorders, right? Pain's always magnified when you're sleep deprived. So part of it's really a 360 view of what are all the contributors to the pain, because it may not be one single thing that fixes it. Often it's really a multimodal approach where we're looking at where can I make an in with meds, with movement, with behavioral changes, or visualization or acupuncture. What are my modalities that will help? But it really, I think, gets individualized to the patient.
When you mentioned the depression anxiety part, that part is huge, and it's tough sometimes because I think when people have chronic pain, a lot of times they'll go and see somebody and talk to them about it, and they will talk about depression or anxiety, or prescribe an antidepressant, and that sometimes gives people the message, well, they just think it's in my head.
Yeah.
They just think that it's not.
Yeah.
And that's not at all what
No.
we're saying. What it comes down to is that pain and depression go hand in hand. If you look at brain scans of people in pain or people that are struggling with depression, you really can't tell the difference about what's happening.
You really get that strong emotional and pain connection.
Right. And it's not that it's something that is just in your head. Well, it is in your head because it's your brain, but it's not something that is in your head. It's that the depression anxiety part make it way, way worse. And any part that's contributing needs to be
on a fire.
Gasoline on a fire.
I always think of it and explain it to my patients, like if they're like, why are we doing this? This is not going to fix it all. As I say, it's kind of like an onion, and I got to keep peeling where I can, fixing what I can bit by bit so I can see what's left and see with what I have in front of me what's the best path forward. It's always that path forward however I get to it. But sometimes it does mean having to take these other steps that may not always make sense, like doing a sleep study or really working on, quitting tobacco or changing eating habits. But really anywhere we can make an in, we want to.
I can tell you what I don't do for chronic pain.
I'm listening.
Opiates, man.
Yeah, no.
Opiates. Opiates are something where, and this has been created by doctors over time, but opiates are potent analgesics. They are very potent painkillers. The way that they work is not by interrupting the pain signal, getting rid of the pain signal, it is disconnecting the affective component of pain, so the emotional component of pain, from the physical sensation of pain. So it's something where people can still feel whatever is causing the pain. They just don't care. It's not something that causes them distress. The problem with that is that your brain is way smarter than that. And when your brain is not getting the normal pain signals, or it's not getting the signals that it should be getting, then it starts to increase its sensitivity to pain.
Yep.
And when that happens, we're talking about all those pain signals that are normally coming in and normally filtered out. Now those signals start getting through. And when people are on opiates chronically, and this pretty much happens to some degree all the time, that means the background level of pain increases. Yeah. So opiates are kind of like a payday loan.
Yep.
They
upfront regulate over time.
Yep. And over time, it means you're paying a lot more.
Yeah. And it's always, I talk a lot about paths, but it's also a bridge. It's a bridge to nowhere because there's no end to that. Yeah. Patients will, request more to cover that increase in pain, and then that upregulates further, and it's this bridge to no successful end point. Yep. So anything that really makes my job harder, I try not to encourage.
Yeah.
Yeah.
I don't think I've ever talked to somebody about that in that sort of way. And sometimes you get people that come in, they'll sort of be trying to get pain medication, something like that. But when you sort of say, look, man, my job is to make it better. I don't want to make my job harder. That's going to make it worse. So let's come up with another plan. I think most people will say, oh, yeah, that's...
Yeah, I mean, not everyone always agrees with me when I try to have that conversation, but I think we definitely have mutual respect that we're going to work on this together.
Yeah.
You know, we may not always think the same, but we're going to try and find a way to improve the pain, you know, however that happens. I think that at least is consistently the takeaway from our conversations.
Yeah. But it's not to say that opiates don't have a role and a place and utility. It's just we don't want to do is just throw a medication at somebody and say, here you go, get out of my office.
Yeah.
Because, it gets them out of your office. It also makes them a lot worse.
Yeah.
And that's not our job.
So what treatments do you like for pain? Are there any in particular that you are your go-tos or just kind of your favorites?
So there's a few different treatments that we use, anti-seizure type medications that can calm down the constant nerve firing. When people have increased background pain, getting that to dial down can be helpful.
Yep.
There's some interesting things that people do with, we were talking about TENS units earlier, so electrical stimulation. There's ways to do that in different places that can lead to down regulation, so just dialing down the pain that people experience. I really love the idea of pain therapy for people. When people
like cognitive
therapy.
Oh, for sure.
Brains have a lot of power.
You could, but it's also to the point that brains can learn new things, and you can teach your brain to think and feel differently.
Yeah.
It takes work, and it's hard.
The monk that set himself on fire presumably was practicing this for years, but it shows how powerful the brain can be.
Yeah.
It has the ability to.
I do think it's the most underestimated and underutilized treatment, though.
Absolutely. Then like you had sort of said before, there's a lot of variability. It depends on a lot of circumstances, but I think the main point is to start and say, this is an issue, this is a problem, and all the other things that are going on are going to be affected by it. So we need to deal with it, and that means
it's never one single prescription. It's always usually layers, peeling back the layers, fixing where you can, and seeing what's left.
Makes me feel good sometimes that there's no one way to do things, because then I realize we're not going to be replaced by robots that quickly.
Heck no, my mission is always to have at least 3 ways to achieve something.
Nice.
Yeah. Well, Rob, it was nice to talk to you today.
As always, great talking to you. Thanks for listening, and we'll be back. We'll be back sometime. I don't know.
Have a good day.
Have a good day.